Dear audience, let me briefly introduce my 3-month progress on my PhD thesis, investigating the effects of biologics on the comorbidities and microbiome in psoriasis. My name is Mária Veronika Kolonics. I'm a PhD student and a medical doctor in the Department of Dermatology, Venerology and Dermato-Oncology, Semmelweis University. My supervisors are Péter Holló and András Bánvölgyi. My scientific methodology expert is Fanny Adél-Meznerics, and my scientific methodology supervisor is Katalin Martin. My vision is a decreased disease burden in psoriatic patients, and my mission is finding the best therapy for psoriasis. I have 2 specific goals. In my first project, we would like to find out which anti-psoriatic biological therapy reduces the cardiovascular burden in psoriatic patients most effectively, while my second project would be a prospective observational study, and we would like to observe the role of the microbiome in the formation of therapy-resistant scalp lesions in psoriasis. The title of my first project is investigating the effects of biologics on the cardiovascular risk of psoriatic patients, and the methodology behind it would be a systematic review and meta-analysis. Psoriasis is a chronic recurring autoinflammatory skin disease with a world prevalence of 2 to 3%. In psoriasis, there is a systemic inflammation which involves not only the skin and joints, but also the cardiovascular system. In the pathogenesis of psoriasis, the main role is played by the dysregulation of interleukin-23, Th17 axis, but there are some other TNF-alpha-mediated pathways. These pathways are also dysregulated in the formation of atherosclerosis and cardiovascular diseases. In psoriatic population, the risk of major adverse cardiovascular events is higher. The life expectancy is 5 years shorter. Psoriasis itself is recognized as an independent cardiovascular risk factor. Only 1-point elevation in psoriasis area severity index contributes to 4% elevation in cardiovascular risk. TNF inhibitors decrease the risk of cardiovascular events effectively. This is an evidence which was published by our research team here under the Center of Translational Medicine. But besides TNF inhibitors, there are some other novel biologics targeting the interleukin-23 Th17 axis, and they are becoming more and more widespread. But the relative risk-reducing effect of these anti-psoriatic biologics remains still unknown. That's why our aim is comparing the effects of biological therapies on the risk of cardiovascular events in psoriasis. A clinical question is, which biological therapy reduces the cardiovascular risk in psoriatic patients most effectively? We would like to examine patients with psoriasis, and we would like to compare the effects of biological therapies on the incidence of cardiovascular events. Our hypothesis is that interleukin-23 Th17 axis inhibitors are superior to TNF inhibitors in cardiovascular risk reduction in psoriatic patients. The clinical implication would be choosing the most effective treatment for psoriatic patients at cardiovascular risk. Here you can see my finalized search key. It had 3 domains, and the preliminary searches were conducted in 3 databases. There was no registered Prospero, but we found some other previous systematic reviews and meta-analysis. The last one was published this year, so 2024, but somehow in the methods, interleukin-17 inhibitors were excluded. Interleukin-17 inhibitors are crucial in the management of psoriasis, so as you can see, there is still an unmet need for conducting a project. Here I listed you some of my key articles. These are all RCTs reporting on the safety of interleukin-17 inhibitors and reporting also major adverse cardiovascular events. And here I listed additional 3 RCTs on interleukin-23 inhibitors. First, I had almost 15,000 hits, and after the duplicate removal in EndNote, this number could be reduced to 11,000. Currently, we are working on the title abstract selection, and the details you can see here on this slide. The title of my second project is investigating the effects of microbiome on the therapeutic success in scalp psoriasis, and this would be a prospective observational study. Psoriasis is a chronic autoinflammatory skin disease affecting 125 million people worldwide. 80% of these 125 million people experiences scalp involvement, which means a serious loss in quality of life. Scalp psoriasis frequently shows isolated therapy resistance and considered to be a difficult-to-treat psoriatic area. In microbiome research, there is a term which we call alpha diversity, and it expresses the variety of species within a single sample. In scalp psoriasis, research has found that both fungal and bacterial diversity correlate with disease severity, and we suspect that maybe not just disease severity, but also therapeutic response may be influenced by alpha diversity. So according to all this, our aim is to analyze whether the alpha diversity of microbiome has a role in the therapy-resistant scalp lesions. Our clinical question is, how does the alpha diversity of scalp microbiome associate with therapy-resistant scalp lesions in psoriasis? We would like to examine patients who have scalp psoriasis, and we would like to form two groups based on the therapeutic response. In the first group, we would like to enroll those patients who show therapy-resistant scalp lesions, and in the second, who show sufficient therapeutic response. As outcome, we would like to observe the alpha diversity, which is measured by the Shannon index. Our hypothesis is that higher alpha diversity of scalp microbiome decreases the therapeutic response in scalp psoriasis. The research implication would be providing information for future studies investigating the treatment of scalp psoriasis. Here you can see a brief summary on my two projects. We wish to finish the first one until March 2025, and the second one, so the observational study about the microbiome research, until May 2026. Now, I would like to close my presentation with the quote of Friedrich Nietzsche, and I think this quote really highlights the importance of critical thinking, which is highly needed in clinical fields. The belief in truth begins with the depth of all truths in which one has previously believed. And I would like to thank you for your kind attention.
I'd like to ask, do you plan to make subgroups based on the different types of biologics?
Thank you for your question. Yes, we are planning to do subgroups according to the active substances, and we will have sufficient data. We are planning to enroll not only RCTs, although I only listed RCTs, but also some observational studies, retrospective cohort studies, and also we have data on real-world studies comparing certain biologics. What we won't include are interleukin 36 inhibitors, because these are used in general pustular psoriasis, and these agents are very novel, so we don't have sufficient data about them.
I would like to ask you if you are planning to include all types of psoriasis in your research.
Thank you for your question. Yes, we are planning to include all types of psoriasis, so not just only plaque psoriasis, but also palmoplantar psoriasis, guttate psoriasis, plaque psoriasis, erythrodermic psoriasis, and yes, so all types of psoriasis are warmly welcomed in our project.
I have a question for your second project, that how would you measure the therapeutic response?
Thank you for your question, and this is a really important question. We measure the severity of psoriasis with the psoriasis area severity index, and we have also another measure for measuring specifically scalp psoriasis, and this is the scalp psoriasis severity index. And we define the sufficient therapeutic response with 50% improvement in this specific index.
I would like to ask regarding your first project that when you read your articles or find your articles, did you find any results regarding that how did the risk decreasing in a specific way in psoriasis if they use different kind of biological therapies?
So maybe do you mean, are there any original studies regarding this topic?
Yes.
Yes, there are plenty other researches regarding this topic. Very high amount of publications are there regarding the about cardiovascular biomarkers, and these biomarkers reduce after biological treatment. Or we also measure the cardiovascular risk with calcium scoring, and also with intima media thickness measurements. And also there are plenty of studies investigating the role of biologics in the reducement of intima media thicknesses. And intima media thickness correlates with the cardiovascular risk, and these biological therapies also reduce the thickness of intima media.
I would have but one question, is that generally a higher alpha diversity means a more well-balanced microbiome. So I'm just wondering why your hypothesis is that a lower alpha diversity corresponds to worse therapeutic response.
You are absolutely right, but in some cases, lower alpha diversity can be more beneficial. For example, the same situation is in the vagina, the same in the urinary tract, and the same may be in scalp psoriasis. So this is not a general rule, but sometimes lower alpha diversity or lower bacterial diversity can be also beneficial in some cases.
Okay, thank you.